Do you all see your patients like in person, or still telehealth is going on?
For me, it's telehealth.
We went
back into lockdown. Maybe my list was starting again.
I see.
Because we've had a big outbreak in our hospital, so they're trying to just keep the hospital clear of people. It's not good.
Yeah.
You too?
Yeah, we do both. We do testing in person. I haven't done any telehealth testing. Everything is in-person testing.
So a very good evening, very good afternoon or good morning, depending on which part of the world you're joining in for the symposium today. I'm Dr. Jayashree Dasgupta, the co-founder and project director of Samvedna Senior Care. And on behalf of the organizing committee for the International Symposium series on contemporary trends in clinical psychology across the lifespan, I would like to extend a very warm welcome to our distinguished panelists, as well as all our participants joining in today. This is the third in the International Symposia series, and the first one, which was held on the 5th of February, this series is being conducted in collaboration with the PSG Institute of Medical Sciences and Research, Department of Psychiatry, and Samvedna Senior Care. The first symposia focused on the very important and increasing issue of technology addiction amongst youth and children. And the second symposia, which was held on the 12th of February, focused on the area of relationships and emotional abuse. Moving across the lifespan, today's symposia offers perspectives on geropsychology. And this is obviously an area that's becoming increasingly important given the aging population globally. So I'm really looking forward to hearing all our panelists speak today. Before we begin, I'd just like to request everyone to try and keep their microphones on mute, as well as their videos off, to minimize any disturbances during the symposia. And feel free to put any questions that you may have for the panelists into the chat box. The moderators will be taking these up after the sessions, after each panelist speaks. We will try to address as many questions as we can. I'd also like to inform everyone that the symposium is being recorded and also live streamed on YouTube. So without further ado, I'd like to introduce my co-moderator, Dr. Sanjay Kumar. He's a senior lecturer at the Department of Health and Professional Development in Oxford Brookes University, UK. And I'd like to hand over to him to introduce our first panelist for today.
Thank you so much, Jayashree. It's really an honor to introduce one of the distinguished speakers on this panel, Professor Irasima Leori. She is an associate professor of geriatric psychiatry in Trinity College, Dublin, and she has been a professor in aging and dementia at University of Manchester in UK before. I have seen some of her work that's really impressive, and I can't think of any better person to start this symposium, giving a perspective of the challenges that everyone is facing in this current situation, the COVID pandemic, and particularly how the elderly population might be more challenged in this particular situation. So it's now Professor Erasmus, please.
Thank you for that kind introduction, and I'm delighted to be here with all of you today. And thank you for taking the time out of your very busy online lives to come and share some of that with us. And thank you very much to the organizers. So I'm just going to share my slides here. How does that look? Does that look okay, like that? And there we go. Yep, everyone happy? Okay, good. So we'll carry on. So I have about 20 minutes to share some ideas with you. And yes, I'm going to be focusing on older people, but specifically focusing on care partners of people who live with brain challenges. You heard that I'm a geriatric psychiatrist, so I work in a memory clinic, undertaking the diagnosis and support of people at risk of dementia or with the diagnosis of dementia. So very rarely do I see people by themselves. I almost always see them in the context of a dyad with a care partner or other family members. And so looking at that interaction and supporting that dyad is what I'm very interested in focusing on today. So I'll touch on some issues before and during the COVID-19 pandemic. So, excuse me, this is where I work. Trinity College Dublin. I was in Manchester for many years, but I've now been here at Trinity for 2 years. So I extend a very warm welcome to everyone if you come our way to come and visit. And it's an old university, about 500 years old. And we're just in the process of electing a new provost, which is a 10-year process. So it's all very exciting where we have hustings and elections going on, all online, unfortunately, but good fun. So Ireland, many of you will have been to Ireland, or at least to the UK. Ireland's a lot smaller than that. Beautiful country. Again, I spoke with a group of people in India not that long ago. And I remember thinking how odd that I'm coming from a country of 5.2 million people and I'm speaking to people in a country of more than 1.5 billion, which is 47 times larger. But nonetheless, as you can see, there's still space for lots of people. So please come and visit. So dementia. Worldwide, about over 50 million people live with dementia, and that does not include those who are at the stage in the pre-dementia stage with mild cognitive impairment. And this is dementia due to Alzheimer's disease or other underlying neurodegenerative conditions. Now, importantly, of these 50 million, over 2/3 live in lower and middle income countries. And why this is a concern is because populations there are aging rapidly, and the numbers of people who are becoming over the age of 65 are increasing, and therefore this proportion of people with dementia will increase even more. And very often these support systems and structures in the health and social care ecosystem may not necessarily be developed specifically for this group of people yet. And as everyone will be aware, there's no cure for dementia. So most care consists of home-based support. And generally, this falls within the responsibility of family members, spouses, and friends. So really underscores that idea that we're talking about a family system here, not the individual. So I'm going to bring back some examples from Ireland, but of course these can be extrapolated elsewhere. Of the Irish population, about 10% of people are considered family carers. And I think that's probably much greater proportion in India, where people tend to live within family units as they age. But that results in a significant number of people. If you think of those specifically with brain health challenges, people with dementia, intellectual disability, or enduring mental neurological illness, the vast proportion will depend on family carers throughout their lives. Certainly those with dementia, at least 80% will depend on informal family carers. And this constitutes nearly half of the overall cost of dementia in Ireland. And in India, I think that would be even much more significant because even a greater proportion of the care is provided in the home setting. So this is a beautiful quote from Eleanor Roosevelt, which I'll share with you. There are only 4 kinds of people in this world: those who have been caregivers, those who currently are caregivers, those who will be caregivers, and those who will need caregivers. So that constitutes all of us at some point. So who are carers? Carers can be caretakers, they can be caregivers, they can be care providers. But I think the term that I prefer most, and many people in this position of providing care informally through the family also prefer this term, namely care partner. In other words, it implies that you have a bi-directional reciprocity in your relationship. Yes, you're giving, but you're also taking. In other words, you get something back. And I think that's a very important dynamic. Very often, this will be, most often, in the case of people with dementia, it'll be the husband or the wife or the person's life partner, but very often an adult child or family member, or in certain contexts, particularly in South Asia, often that'll be the daughter-in-law or the eldest son, which is less commonly the case here in Ireland. Now, I don't need to spell this out, but just really to reiterate that the roles of the carer cover A to Z of a person's life, from the basic daily activities, including eating, bathing, dressing, transferring, toileting, walking around, but also personal care, emotional support, medication management, disease management, attending appointments, and also taking over the administration of the family. In other words, the person has to look after their own life and the life of the person who is the care recipient, plus the whole running of the family and everything that entails. So you can imagine if somebody in middle age is taking on that role and they have a career or a job outside of the home, and they have children to look after as well, that can become extremely challenging. Which means that very often we see the impact of care provision in older people being physically demanding and mentally exhausting, resulting in negative feelings, stress, burden, decreased socialization. In other words, you have no time to step outside the door, not to mention during COVID times. And of course, loneliness. Even though you may be with somebody all the time, the loneliness of losing the person you love, decreased quality of life, worsening mental and physical health, to the point that at times, carers can be called hidden patients. So again, from my perspective, sitting in the memory clinic, focusing on a person who presents with memory impairment or cognitive difficulties, and I'm wondering whether this is a diagnosis of Alzheimer or other forms of dementia, I have to consider that next to them is potentially another patient as well. So this is a small survey that was completed before COVID by Family Carers Ireland, which is one of our charities. And what it found is that clinical depression in dementia carers was 3 times the national average, 3 times. And again, keeping in mind that this is a group of people who are predominantly older themselves and also have comorbid or concurrent health conditions. Poor outcomes were reported, self-reported by respondents, poor outcomes meaning physical and mental outcomes in over 90% of respondents, and over 83% reported that there's no time for hobbies or socialization. So this is somebody who is at the time of their life when it's precisely what they should be doing. Potentially their career and their work life is over and they want to undertake new hobbies, socialize, but of course all of that is not possible. So let's throw COVID into the mix. What has happened to the care situation for people with brain health challenges, particularly dementia? This was a small survey undertaken by Alzheimer's Society Ireland to describe how caring has changed. Now, again, this will differ somewhat from India because many people in Ireland, of course, will be seeking support and care outside the home, which is less often the case in India, where outside care is just starting to develop, as far as I understand. But, for example, loss of visitation rights or access to a care facility, if the care recipient, your family member, is in some kind of institutionalized setting. That's particularly the case for people whose adult children have intellectual disability and are living in some kind of group home, which is very common. In other words, with people with intellectual disability, as they get older, there's a tendency for them to move into semi-independent living so that they can participate more fully in society outside of the family home. But that care is cut off immediately when the COVID restrictions kick in. Not being able to provide face-to-face care, loss or reduction of outside support. So on the one hand, you've got the hypo-caring situation where you've lost your ability to provide care and support and daily visit the institution where your loved one is, or suddenly you're in the hyper care situation where you are doing everything by yourself without any outside support. Loss of respite facilities like daycare, the need to wear protective clothing, which has been a huge issue, both in institutions and outside. In other words, that loss of ability to show facial expression, to be able to communicate particularly because the vast majority, upwards of 80% of people with dementia, have hearing and vision difficulties, and also the difficulty in recognizing who is in front of them. So all of these communication barriers increase the barriers on day-to-day living. So spending too much time together, as well as spending too little, being in a confined space together, and particularly in Ireland, people tend to live in very, very small surroundings because the cost of living is very, very high here. The loss or reduction of information about the person you care for, particularly if there's a new diagnosis of dementia, suddenly people are overwhelmed. They're here with this issue all by themselves. They don't have access to the kinds of support groups, chat rooms and things. Now, I will say, of course, that this has rapidly changed over the past year, and people have incredibly rapidly upskilled in terms of their online and the remote access. And what used to be live is now happening within the remote space. However, that still is for a certain proportion of people in the population, they don't have access to that, particularly if they've got hearing and vision and cognitive difficulties. And a big issue also is grieving alone. In other words, when somebody passes away in hospital, when they pass away in an institution, and certainly in Ireland, the biggest victims of the COVID pandemic have been care home residents. And those deaths have not been in the presence of their family members, which is one of the great tragedies, of the many tragedies of the pandemic. So here's a very nice quotation from Family Carers Ireland. It described the first wave of the COVID-19 restrictions. The blanket withdrawal of supports such as home care, respite, personal assistance hours, and residential care during lockdown forced many carers to care alone, around the clock, and without the support of extended family or friends. And I mean, some evidence to support that. Age Northern Ireland found 60% increase of calls to older adult helplines within the first month of the lockdown. So the types of things that the survey also threw up was that carers are presenting in crisis. They're presenting because of lack of support, because of extra workload and being overloaded, exhaustion, anxiety, loneliness, and social isolation. And for many people, they found for the first time that they've had to become carers, because for some, the support systems were there and they never had to take on that role, particularly when they themselves are frail and at risk. And why does this matter? Well, it matters in and of itself, but particularly in the context of the pandemic, increasing the morbidity and mortality of these mostly older caregivers, undermining their efforts to combat the virus, because these negative emotions, this stress, this burden, lowers immunity. So I'm just going to share with you the findings of a few studies done by my lovely colleague, Dr. Sabina Vater, who was one of my PhD students, and she's now moved on. And she did a number of studies looking at the dyadic interaction, in other words, the interaction between spouses where one had a brain health condition, namely dementia. So I'll just share some of those findings quite briefly and then come back to COVID. One of the first things she did was a cross-sectional study of 76 care partners, most of whom were spouses. And no surprise, this is what she found. 50% said they were stressed. Now, this was before COVID. A third were anxious, a fifth were depressed, a third were burdened, this by their own report, and 50% were dissatisfied with their relationship. So it paints a pretty bleak picture. Now, interesting, in looking at that dyadic relationship, because the strength of that relationship will often determine whether the care situation can survive or not, or whether it breaks down. But what we see that it's predicted by is depression in the carer, the perceived burden in the carer, and also the level of apathy in the person with dementia. Now, there's quite a lot out there in the literature about levels of agitation, aggression, psychosis. So hyperbehavioral manifestations in the person with dementia causing increased burden or stress in caring. Our study didn't find that. In fact, we found apathy. And apathy is a very difficult syndrome to detect and also to manage. But as you can see, it's highly predictive of a number of outcomes. So, in thinking about some of these challenges, sometimes the focus is on this idea of the carer surviving, just getting through. And sometimes in the beginning of the pandemic, that was okay. But now, a year into it, we have to start shifting that narrative and moving from this idea of surviving focusing on stress, burden, anxiety, and so on, and really start thinking about thriving and trying to understand what is it that allows carers to thrive rather than just survive. And I think particularly because many of you will be in the psychology field, I'm not, I'm in the psychiatry field, which means I'm a broken brain doctor, not a brain health doctor. But psychology is really pushing this idea of looking for the positives, the positive psychology movement, and thinking instead, rather than the 50% of people who are stressed, what about 50% are not stressed? 66% are not anxious, 80% are not depressed, 50% have good quality of life, 50% are satisfied with the relationship, and 2/3 are not burdened, and 80% consider themselves resilient. And I think understanding that and harnessing that positive energy can really make the difference between surviving and thriving. I'm not going to be talking about resilience because that's a whole other field which we won't have time for. But just to really make the point that in thinking about our patients in the clinical context, such as mine, we need to really be tapping into this idea of resilience. In other words, the capacity to bounce back from adversity, to maintain psychological health and adapt and grow. And if there's one big worldwide experiment of adaptation and growth and trying to manage adversity, is this pandemic. And again, the difference between the survival and the thriving. And it's this resilience that enables care partners to provide care and flourish despite the increasing demands. And sometimes just recognizing that and articulating that with people we work with can make a significant difference, finding their strengths and helping them recognize those strengths. Now, in the last 5 minutes, I'm just going to shift a little bit to talk about loneliness and social isolation, because this is some ongoing work. And of course, it has suddenly become a huge issue in the COVID-19 pandemic. Just to make a quick distinction, loneliness is a subjective sense of inadequate quantity or quality of social contact, and the longing and the unfulfilled close and emotional relationships of others. So the sense of being alone and lonely. That's different from social isolation, which is essentially being cut off, which is an objective and quantifiable lack of or reduction of social network size and social contact. So you might be socially isolated, but you might not be lonely. And you might be lonely, but you might not be socially isolated. You can be lonely in a crowd. So these are different constructs, but very often they do go together. So why is this important for older people? At the individual level, there's a huge amount and growing level amount of evidence showing that people who are lonely or socially isolated have more rapid cognitive decline, are at higher risk of dementia, have greater physical mobility and higher mortality rates. Now, this one here in the middle, dementia, thinking about the carers of people with dementia and other long-term conditions who are older are themselves at greater risk of developing dementia. Then if you throw into the mix social isolation because of the pandemic and loneliness, which also is a risk factor for dementia, suddenly you're increasing the risk that many-fold. Moving from the individual to the societal level, we can think about this idea of emotional contagion. And again, in the context of a pandemic, that becomes important. Emotional contagion is the rapid spread of both either positive and or negative emotional states that can go through a community like a virus. So if the negative emotions are worry, fear, loneliness, loss of hope, and that all this that comes along with the pandemic, the impact on society will be far-reaching. So I'm just going to share the results of a small study with you, and then I'll wrap up. And this really stresses this idea of the impact of loneliness and social isolation within the dyadic context. And this is work that I did with my lovely young colleague, Azri Maharani, using actor-partner interdependence models on a cohort of people from 4 different centres in the north of England, of people who attended memory assessment services. So within this cohort of people attending memory assessment services in these 4 different sites, what we did is we looked at loneliness and social isolation in people who attended the service, most of whom had different forms of dementia, but some people were in the earlier stages in MCI. And we looked also at loneliness and social isolation in the care partners who they attended in the clinic with. We did that at baseline, and then we looked at 12 months follow-up. So what did we see? If we look here at the loneliness in the care partner, it predicts the depression in that same person and anxiety in that same person in the care partner 12 months later. So if you're lonely now, in 12 months, you're going to be depressed and anxious. We did not see any impact of this person's loneliness on the person with dementia. However, looking at the person with dementia, if they were lonely at baseline, at 12 months they were depressed, at 12 months they were anxious, but it also predicted depression and anxiety in the care partner. In other words, the psychological state of loneliness of the person with dementia significantly impacted on the care partner in a contagion, you can hypothesize, in a contagion kind of way, but not the opposite. It's almost as if the person with dementia was less aware or unaware of the loneliness in the care partner, which is an interesting dynamic. And again, thinking about COVID and how that impacts. So I'm going to finish now. I won't give you any results of this because we're still in the process of analyzing it, but some people on the call may have contributed to this, so thank you very much. This is the Click Care survey in which we looked at coping with loneliness, isolation in COVID-19 that we started back in May, and the survey closed in November. And I was responsible for looking at the bit within the survey of care partners of people with brain challenges. And what we're trying to do is understand how people coped during the pandemic, particularly in relation to loneliness and social isolation. And what was very unique and interesting about the scale is that we were able to, or the survey rather, we were able to include validated scales of loneliness as well as social isolation. Because there's a big literature out there, but very few of them include validated scales of both of those constructs. So this is what we found, and I'll just focus here on the South Asian group. So overall, we're able to collect data from over 23,000 people, of whom over 5,243 were carers of people with long-term conditions. And as you can see, the South Asian total here, we've got nearly 2,000 people in total, which are over 450 care partners. So we're still in the process of analyzing those data, but it'll be absolutely fascinating, particularly comparing the other regions where care patterns can be very different, particularly if you're thinking people more living in a family context versus being isolated or institutionalized, and all sorts of other cultural and contextual differences. So maybe next year, I'll come back and give you the results of this, which I think are going to be absolutely fascinating. And I think I'm going to end there, and I hope I haven't gone too far over my time, and I'm going to stop sharing. So thank you very much for your attention.
Thank you so much. That was really a wonderful talk, and that is quite contemporary. I have few questions, although one question I would like to slightly modify that might be better suited for your kind of experience. And part of that I might like to take with Dr. Om Prakash. But the question is about the diagnosis and disclosure of diagnosis to patients or possibly the family members. So what kind of procedure do you follow for disclosure of diagnosis?
It's an extremely important point, because very often, and evidence shows that it's often done extremely badly. And when people break bad news in the clinical context, very often family members take away 1 or 2 messages, and usually they're the wrong ones. And 5 months later, you can ask them, did they get a diagnosis? No, we didn't. Nobody told us anything, except maybe that things were going to be very bad. So disclosure of diagnosis needs to be done very, very carefully. I can't point you to specific guidance, because within our own clinic, we've developed our own way of managing it. However, I do know that the NICE guidance, the National Institute for Health and Clinical Excellence guidelines for dementia, it does mention some aspect of this. But ultimately, I think every site needs to develop its own way of working within its team context. So the way we do it in our clinic is that when we have gathered all our diagnostic information together, we call the patient and the family member in to the clinic. Obviously, we do this a little bit differently now, but in an ideal circumstance, we sit with the clinician, the social worker, usually just the 2 of us, and we discuss the diagnosis, starting with asking the person with dementia or the patient and their family member, what are their expectations? What do they think this is all? What are they worried about? And surprisingly, how much people are aware and already know. And so taking that information, one can then start moving very carefully into the discussion about the findings, on the results, on the investigations, and then start moving into, well, yes, this is positive, this isn't, and what does this mean for you? So I think that's the key thing, is starting with managing expectations and finding what people are afraid of and what they already know. The second point is trying to instill some degree of hope, but the caveat, not false hope. Yes, that people can live well with this condition and the evidence supports it, provided these supports are in place. So it's not a negative story of you've got this condition and you're going to just go down and die. However, at the same time, we don't have a cure and we can't change the trajectory unless we can help you live better with it. So it's focusing on that day-to-day experience of living with this neurodegenerative condition for which there is no cure, but recognizing that you can still live well with dementia. And I think that's the conversation that needs to be brought into the room.
Thank you so much. There is a comment rather from Dr. Om Prakash. He agree with your idea that how challenging it would have been during this COVID period, and particularly in inpatient setting, looking after those elderly patients. There is a question about how do you distinguish between the loneliness and social isolations in those patients particularly?
As due to old age, they do feel loneliness. How's it linked? Okay. So yes, it can be challenging, but I think very often they are linked. Loneliness tends to be a subjective sense of being alone. In other words, you don't have to be socially isolated. You can be in a crowd. And I think this is a particularly important concept in the settings whereby people live in multi-generational families, and there might be 5, 6, 7 or more people within a family context. That doesn't mean a person isn't lonely. And so it's about trying to understand the experience of that person and how they perceive their reality. This is particularly important for people who are older and living with dementia, because very often they might, again, be isolated in a crowd. They might spend all their day with a carer who might be a young person, might be uneducated, might not be able to relate necessarily to that person. They're entirely within the family context with the idea that let's keep the person safe and wrap them around. What they're missing is interaction with their peers, people of their own age who have the same shared experiences from their childhood. And so, again, they may be with a carer 24/7, but it's isolated from the meaningful relationships they might have with other people, such as their peers. And this kind of dynamic is really starting to play out intergenerationally in families where young people are further and further away from the world that their elders have inhabited and understand. So in other words, the world of technology, understanding traditions, all these sorts of things. Even though you're living together in the same house, your worlds are completely different. And I think that's an important construct, again, to think about being lonely despite being together. So you're not socially isolated, but you're lonely. Does that kind of address the question? I hope so.
Yeah, certainly it does. Yeah, if there are any, we have some time, so if I can ask some questions meanwhile to fill in the gaps. So you have talked about that there are huge burden on caregivers. Is that particularly due to the chronicity of the illness, which could be also possible in many other chronic conditions? Or is it something very unique because it is a cognitive and brain disorder?
I think that's a very good point, and I think it's both those things. And another element as well. I think, yes, because it can go on for many years. It is a chronicity. It is also the fact that you know this is only going to get worse. So it's degenerating by definition. But then you add in the element of being a cognitive disorder and that gradual chipping away of the personhood of the person with the diagnosis, and that impacting on that spousal relationship. In other words, your best friend, your partner is gradually disappearing even though they're in front of you. So all of those dynamics come into it. And I think a very nice model is looking at people with Parkinson's disease. So very often carers can manage very well in the earlier stages of Parkinson's disease when there are motor issues that they need to address. They can support somebody with dressing, managing their meals, handling a knife and a fork, getting in and out of a car, getting up and down from a bed. That's fine. When the dementia and the cognitive impairments start to kick in, suddenly the care burden goes from here to here. It's like falling off a cliff, or well, actually stepping up, going down the other way. And it's the same impact on quality of life. So the care burden and the quality of life of the carer and the person with the condition. And that's because the cognitive and emotional elements start to come in, and it moves beyond the physical. So I think exactly as you've said, it's all those elements combined. And I think maybe the other element that we need to keep in mind is that, as I pointed out, very often the care partners are older themselves, older, vulnerable, have coexisting conditions. Sometimes they themselves have brain conditions or starting with mild cognitive impairment. And so thinking about COVID and the idea of cocooning older people, both the carer and the person with dementia are in the high risk group. And so both of them had to be cocooned. And that's, again, this dynamic of being cut off from loved ones, grandchildren, and so on. So I haven't been following too closely what's going on in India, but here in Ireland, we're in our third severe lockdown. And where just around Christmas, families were getting together again. Of course, we had a sudden peak in rates of the infection, and we went into complete lockdown. So suddenly families are broken up. And at most now we can do is a 5-kilometer radius. So it's a very challenging time. And in the clinic, and I'm sure people out there who work with older people have seen this as well, we see the few who do come into clinic or we see remotely have taken a significant in terms of their cognitive abilities. So people with mild cognitive impairment rapidly move into dementia sooner than we would expect. People at mild dementia fall down into more advanced stage dementia. People with frailty, generally their physical aspects, fall into significant frailty. So the first day out of lockdown, they step out of their front door, they fall, they break their hip, and they're in hospital. And that's a common story, unfortunately.
Okay, thank you so much. That was very insightful. I think I will now hand over to Jayashree for the next part of the symposium. Thank you so much.
Thank you, Sanjay. For the next talk, I'd like to introduce Dr. Kavita PR. She's a clinical neuropsychologist in the Center for Transitional Neurorehabilitation at Barrow Neurological Institute, Dignity Health, and St. Joseph's Hospital and Medical Center in Phoenix, Arizona, USA. She holds a PhD in clinical psychology from the National Institute of Mental Health and Neurosciences, Bangalore, India, and has completed her residency and postdoctoral fellowship at Barrow Neurological Institute in clinical neuropsychology. She has extensive experience in neuropsychological assessment, cognitive retraining, psychotherapy, as well as leading psychoeducational group therapies and international publications to her credit as well. She's very interested in establishing empirical evidence for neurorehabilitation outcome and is also the principal investigator of a very interesting project on milieu-oriented neurorehabilitation in patients with brain injury. So a very warm welcome, Dr. Kavita, and I invite you for your presentation.
Thank you so much, Jayashree, for your kind introduction. I would like to thank everyone for organizing this wonderful platform where we can all share our experiences and ideas and come together to figure out ideas, because I think caring for aging population, one of like as I was reviewing, I came across this term called dementia tsunami. So we can figure it out. So I'll start sharing my slides here. right. Hope you can all see the slide with no problems. So what I plan to do today in this next 25 minutes is talk a little bit about prevalence of dementia in India, the factors influencing caregiver burden a little bit, and then most of the time will be spent on the role of neuropsychological evaluation in diagnosis and management of dementia, as well as how do we include the caregiver in this entire evaluation as well as management process. This graph is little alarming, like I mentioned, dementia tsunami. So you can see that this gray shade is where the rate of growth of dementia worldwide in 2015 till 2050, the Alzheimer's Disease International, they have projected. And you can see that how the rate in the high income countries seems to be not growing as much as the rate in the low and middle income countries, which means that it's very important for these countries to be looking at how do we prepare so that we can care for our elderly as well as the caregivers, because that's going to become a huge problem for the entire country itself. So in India, currently around 4.1 million people live with dementia. In 2025, it's projected to go up to 6.35 million. And in 2050, it's going to be around 13.3 million. So the other issue here also is the number of people with dementia is increasing, but at the same time, there is not many people are getting diagnosed and getting the treatment. So even in high income countries, only 20 to 50% of dementia cases are being diagnosed. In low and middle income countries, there is a study based on one Indian study. Apparently, 90% of people with dementia remain undiagnosed, which brings a huge problem for caregivers. Because if someone has a diagnosis, the caregiver burden obviously is in a different direction. If someone does not have a diagnosis, you can only imagine how the extra burden can be, because they do not know what their loved one is going through. They have no idea why they are behaving in such a way or how to help them. That is a very difficult situation. We may have to look at how we address these situations. In India, another issue is also, like Dr. Erasima pointed out, caregivers usually, the caregiving is mostly done by the family members, and external support system is not well established. It's probably because of our cultural factors as well. So full-time care capacity is estimated to be available only for less than 2,000 people, based on a study from India. So the caregiver burden is defined as the extent to which caregivers perceive that caregiving has had an adverse effect on their emotional, social, financial, physical, and spiritual functioning. So you can see, like Dr. Erasima pointed out, it affects several aspects of an individual. And it's bad enough that it does not have an ICD code or a DSM code that providers could say, oh, someone is in with a caregiver burden, we need to treat them. So I hope formally we will do something about getting necessary help for them. One another aspect that affects caregiver burden is that 1 out of 10 people with dementia is, only 1 out of 10 people with dementia is formally diagnosed and treated. This is related to very poor awareness in society and among professionals, very low specialist or trained human resource capacity, unaffordability of treatment, lack of public health priority for dementia. I'm going to kind of skip the reason why we need to focus on caregivers, as this has been extensively discussed by Dr. Irasima. So that, and just to briefly point out, some of the determinants of caregiver burden are, the patient determinants are like duration, severity, cognitive deficits, the extent of deficits, the lack of self-care, depression, apathy, and disruptive or inappropriate disinhibited behaviors. The caregiver determinants are adaptability, the role captivity, the perception of the caregiver feeling like they are stuck in this position, like they have no way out or there is nobody else to help them, and that overload, their own physical health, their perceived support, feeling that they have some help to call for, and then their relationship with the patient at the current situation as well as prior to the diagnosis of dementia itself. The caregiver intervention needs to focus on taking the caregiver as part of the treatment team, like including them in discussing about what are the ways they can manage the patient's symptoms. Helping the caregiver to see how can they take care of their own health. Are they making appointments for their own physical checkup? Are they going to gym? Education and information about the dementia itself, use of support technology. For example, when people with dementia have need 24-hour supervision because they have a wandering risk, so the caregiver cannot go anywhere. So are there ways that they can get some technology involved, like the cameras that they can install so they can keep an eye on the caregiver while they were away for an hour for a walk or in a gym? Coordinating care with the care team, like it is important for physicians and the psychologists treating the patients to talk to the other team members to share the ideas which relieves the burden on caregiver, and helping the caregiver to access respite care. Some of the things that are available in the United States are support groups, not only support groups, but there are caregiver available through different programs that some caregivers can go in, be with the patient for an hour or two so that the caregiver can go for a walk or go for grocery shopping. So what is the role of a neuropsychologist in dementia care? The first to talk about how are these neuropsychological tests helpful. The neuropsychological tests are known to have better sensitivity and specificity in predicting or in identifying the cognitive deficits when compared to the cognitive screening instruments, which commonly used ones are the mini mental status examination and the MoCA. The neuropsychological tests help to not only identify the cognitive deficits, we can also differentiate, is this cognitive decline a part of normal aging, or are they in the mild cognitive impairment stage, or is it in early dementia or later stages of dementia? It helps predict progression of disease better than neuroimaging when we monitor someone on a regular basis using neuropsychological tests. It guides both treatment and real-life decisions. For example, helping the family understand why a patient cannot be relied on for financial decisions or paying bills or be able to drive. Neuropsychological testing provides enough data to help them see why someone should not be engaged in these activities alone. Ability to detect distinct patterns of cognitive decline. So, neuropsychological tests can show someone has Alzheimer's disease, where you see severe memory problems, or do they have frontotemporal dementia related to behavioral variant or language variant based on their profile. And also, it helps in differentiating depression from neurodegenerative disorders. Commonly used neuropsychological tests are, so when we have a patient, usually in the beginning stages, we are able to test them for 2 to 3 hours. Yes, they are able to engage for 2 to 3 hours and go through the testing. So we are able to give an extensive battery so we can establish a baseline. Commonly, we give them a few measures of intellectual functioning from a Wechsler battery or an advanced progressive matrices. Attentional tasks using trail making test, digit span, or visuospatial span. Processing speed is very important aspect. Again, trail making, digit symbol coding, symbol search. One or all of these tests could be administered. Most of the time we give at least 2 of them so that we know if there are any fluctuations. Memory functions are usually extensively measured, assessed using list learning, logical memory, verbal for verbal ones, and then for visual memory, Ray complex or design learning, pattern learning from Wechsler memory scale. And then for language tests are very important because they play an important role in distinguishing or identifying some aspects of frontotemporal dementia. The naming tests, reading tests, vocabulary, semantic fluency, sometimes even aphasia batteries could help in that situation. Motor functions, we do take a sample of motor functions with finger tapping and groove pegboard. Executive functioning through trial making test, Wisconsin card sorting, phonemic fluency, and Tower of London. So the emotional and functional status, depending upon the age, sometimes patients from 65 to 70, 75, I feel comfortable giving them a longer one, like a Beck depression inventory or Beck anxiety inventory. But if they are like in their 76, 78, or 80s, then we do the geriatric depression scale or geriatric anxiety inventory, which is very short ones. In the severe stages of dementia, then we use just neuropsychological screening tools like dementia rating scale or a repeatable battery for assessment of neuropsychological status, like an R-bands, which gives us a sample of the functioning. It's mostly these screening tools are used to assess a patient with severe dementia, mainly to help the caregiver understand the extent of the severity of the deficit. And it also gives information to the treating team. These screening tools in that stage is not much directly helpful for the patient because their awareness about their problems at that stage is not in a good place for them to be able to understand why are they even doing the testing. So once we do the neuropsychological test, what do we do? So if we, then we get to see that is the deficit normal for the age? So it's very important for us to compare the performance using normative data that are age appropriate. And then we try to see if there are norms for cultural background as well. If we see that the F deficits are not for normal age, then we look for what pattern do they have? Do they have a dementia, cognitive decline? So the thing is, it's hard just using neuropsychological tests to tell someone has dementia with one assessment. We have to rely on the clinical history as well. So usually we recommend the patient be followed for another testing in 6 months or a year. This chart is a very useful chart in the clinic when we are trying to determine, like, does someone have a mild cognitive impairment? Is it an amnestic type or a non-amnestic type? If it is amnestic, like meaning, do they have primarily, they have only the memory domains in the neuropsych test is they have deficits, then we categorize them as amnestic. If they have, their memory is good, but they have visuospatial skills or executive functioning deficits, then we categorize them as non-amnestic MCI. So once we have categorized this, then we go and look for, do they have single domain amnestic or multiple domains? So do they have impairment in memory as well as others? Or do they have no problems with memory, but they have visuospatial problems and executive functioning difficulties? So you kind of get to keep going through this chart, so it helps the clinician guide. So what is the problem for them? Like, do they have MCI and which type? So now let's move into case history so we can get a little bit of more specifics how the neuropsychological tests are used. Here I'm presenting a 75-year-old man, right-handed, who has 10 years of education. He comes into a clinic as thinking that he has Alzheimer's dementia. He comes alone. He has been contacting the office on his own. He has been independent. His cognitive complaints are short-term memory loss, losing train of thought, and route finding difficulty for past 1.5 years. And his recent MMSE score was 24 out of 30. Physical complaints, some features of Parkinsonism, balance problems, tremors, has stooped posture. His MRI shows bilateral periventricular white matter signal lesions, which indicates chronic microvascular white matter ischemic changes that are age appropriate. The patient has a history of boxing several years ago. He was knocked out 2 to 3 times and had a very brief episodes of alteration in consciousness. On our neuropsychological evaluation, on the cognitive screening, his dementia rating scale. So in this results section, I wanna guide the listeners that anything that is in red or impairments, the blues are they are functioning within the normal limits. So his overall dementia rating scale showed that he was severely impaired. Among the other functions assessed, you can see that the visuospatial skills, he has problems, attention problems, and then with his executive functioning, he has problems with mental flexibility and set shifting. Rest of the functions of processing speed, language, and his verbal intellectual functioning all appears to be within the normal limits. With regard to his learning and memory, so learning and memory tests serve as a very important aspect of the dementia, the assessment, because we get to see, are they making any gains as we give them more trials, or is someone learning with repetition? You can see that this person has not shown much changes. He learned only 4 words In the first trial, 4, 6, 6, and 5, a very flat learning curve. Then immediate recall was only 1, delayed recall was 3, which shows that neither he has a good capacity to learn or remember what he has learned. And the recognition serves as another important way to see whether there is anything in the storage. So you can see that he has problems recognizing all the 15 target words and made 10 false alarms, like he identified 10 non-list word as appearing on the list because he did not know. And it looks like he has a better logical memory. So it looks like he was able to learn if there was some structure. You know, like logical memory is just telling a story. It looks like he has a better memory when there was structure put together. But same for his visual learning and memory also. He didn't have, he has a flat learning curve, has poor memory, and then his recognition was not as bad as the word list. Looking at his mood, he reported mildly depressed. And we also do a functional status assessment where we ask the patient and caregiver to complete forms that are similar, which goes through activities of daily living and other areas to see what is the awareness of the patient. And sometimes we see that patients are reporting very few compared to their family. So obviously the family reported he has difficulty with initiation, memory, accepting criticism, communication, pragmatics, managing mood, understanding new instructions. So when we summarize, so I test the patients, and then what we do in the clinic typically is then we have a 30 to 45 minute meeting to go over the tests. And this is very important because even though the patient and the family comes to us with a diagnosis knowing that so-and-so may have dementia or already has dementia, going through this test results helps them kind of affirm from where or how their doctors are making this decision. So we review the patient's strengths, and then we ask the patient, did he find anything difficult for him on the testing? And then we are able to show them where we find these challenges and how we compared his performance with his age group, people without any neurological problems, so which helps them understand. Not always the feedback process goes smoothly, but yes, we then try to meet with them more than once to help them adjust to the diagnosis that is being made. So in this case, the deficit pattern definitely shows a degenerative process, but this could be related to Alzheimer's or Parkinson's. So the Alzheimer's, typically we see that they lack benefit from the repetition or recognition. Parkinson's, we see they show more of an executive dysfunctions and visuospatial deficits. The patient doesn't seem to have any problems related to Lewy body disorder because there's no alterations in consciousness in his daily life. He doesn't have true hallucinations or REM behavior disorder. The feedback, this is an important, based on all the test findings, it is clear that the patient has memory problems and he needs close supervision for 24 hours. He shouldn't be driving. Good thing he lives with his wife. He needs help with higher decision-making and medication management. Strategies are also, we teach them how to use, we teach both the patient and the caregiver, how could they use a calendar system? How could they take notes in important meetings? We demonstrated, I actually, as psychologists, we all take notes, and I tell them, look, I take notes so that I can remember what I'm telling you. So it is okay for you to go to your doctor's office and say, hey, doctor, can you tell me what are the things I need to remember and take notes? Or ask your doctor to give you a printed recommendation form so you can take it home with you. The importance of sleep hygiene, having a routine, bedtime, wake up time, having regular meals, being able to take medications regularly. And we live in Arizona, which is an arid place. So hydration is very important because there is a lot of times fluctuations in cognitive and emotional functioning related to poor hydration is well known here. So we emphasize they take care of their hydration needs and be aware of fluctuations in these functions. Caregiver focused. How do we use this information to focus on the caregiver? So we try to see what is the caregiver's age, education, are they employed, what ethnicity background do they come from, what is the cultural background, and how does that impact their role as a caregiver? What values do they have? Because some cultures that, like we have here, they do not feel comfortable getting external help, like how we see commonly in India. So we have to be very mindful before we recommend them, send them to a daycare or ask a caregiver to come in. So we try to recruit their family members to support. Physical and mental health of the status of the caregiver is also important. Or do you have health issues and are you taking care of it? It is good to get a sense of how is the relationship with the patient is important. Jayashree, I'm seeing a orange sign. Does that mean anything?
Yes, if you could just wind up. I think we have a number of questions, so we'd like to keep some time for that as well.
Give me 2 minutes, 1 minute, I'll be done. Who else is available for caregiving? This is a very important, a lot of times caregivers are pleased when we ask, are you the only one giving caregiving? Who else can we recruit? And how can we involve sons or daughters or grandkids? So these are these are some ways we try to incorporate in the feedback session. This is how we engage them as a part of the team. So which many of the caregivers feel validated that what they are going through, their caregiver burden, is real. All right, I'll stop here and then we'll get to discuss. Thank you.
Thank you very much, Kavita. I think that's a really interesting presentation. You've really highlighted the role that neuropsychological assessments play in in terms of the entire diagnosis process, as well as helping families understand, the whole treating team actually understand how to provide interventions. I think let's just jump straight into some of the questions that we have. I can see we have a number of questions, so I don't know if we have time to take up all of them. But one of the questions is about cognitive rehabilitation efforts and how clinicians manage cognitive impairments and the kind of rehabilitation efforts. Would you like to share some thoughts on that?
Yes, yeah. I know when we talk about cognitive rehabilitation, cognitive retraining, and particularly the computerized cognitive retraining, is a huge industry. And a lot of people have apps and they tell me, I do this app or that, like Brain app or Lumosity or several applications are available. I spend half an hour, 45 minutes doing these things. So as a clinician, like one of the recommendations that we make for these cognitive retraining programs is it is beneficial to provide a structured activity for the patients with dementia, because many a times the unstructured routine, not having stimulation, cognitive or any forms, is one of the important risk factors. So in a way, doing some of these computerized tasks provides as one piece of cognitive stimulation, but that is not going to be the only piece that's going to keep them stay away from dementia. So what we recommend is like spend 20 minutes or 20 minutes, maybe keep it as an activity. You do exercise for 45 minutes. This is just for 20 minutes, because many of our patients have perseveration. So if you say do it, they just keep doing it over and over, and they may be making so many mistakes, nobody is correcting them. So we actually recommend them work with a speech therapist or an occupational therapist who can help you. If you have a problem in the task, how do you get over it? And how do you develop strategy? That is much more meaningful than just doing them on their own. And cognitive rehabilitation, to quickly answer your question, cognitive rehabilitation is helpful, but the most important goal of cognitive rehabilitation is to include a structured activities for them. Those are goal-oriented. Some of them are leisurely, some of them are productive. So that gives them a sense of accomplishment, which gives an upliftment for their mood. So, like it is a combination. So when we work with patients and families, one of the things we very slowly, we can't do this in 2 or 3 sessions. What we do is we very slowly start building that structured routine. Like you ask, what do you do every day? And you find out what is their favorite thing. Many patients will say, I love to walk. So then we say, let's find a time where you can walk regularly. How much do you want to commit to? 3 times a week, 4 times a week? So then we very slowly, we just push in that we are building the structure. So that is the important aspect of cognitive rehabilitation, I see.
Thanks a lot. We have a couple of questions which have asked about specific cognitive assessments. I think there's one question about the utility of the advanced advanced progressive matrices to SPM, and about any specific assessments for frontotemporal dementia apart from the NIMHANS battery for the Indian population.
That's a very good question. So the advanced progressive matrices and standard progressive matrices, they both are a very good measure of overall intellectual functioning, especially when we don't have, they are culture-free norms, right? Like they are culture-free tests and they are very good measures. We don't have to have the whole Wechsler battery to get a sense of intellectual functioning. But the problem is with those two relying more on the visuospatial relationships. If a patient has a predominantly visuospatial deficit, it may not give us the correct, like good estimate. So that is the only place where you will have to rely on some verbal reasoning measures to get a sense of where their IQ is. For frontotemporal dementia and the NIMHANS battery, one of the things, I think for in NIMHANS battery, we have good number of executive functioning tests like Wisconsin chord sorting, animal fluency, phonemic fluency, Tower of London. They are all very good measures of the frontal lobe, but the language functions where we need naming test, reading test, those are, when I was a grad student in India, we did not have much of those tests, but I think that is the place where we need to develop them for our Indian population, is the naming and the reading test.
And clearly, I think those are areas where there are inherent challenges due to the vast number of languages itself. So yes, I think these are definitely very unique challenges that we do have in India.
Yeah, and one quickly, the social cognition, like that's another area for frontotemporal dementia, is like, the tests specific for social cognition. And we know that the way we show empathy is different in different cultures. So we may have to come up with those as well.
And on that note, I think you've really brought out the need for a lot more work from a research perspective, from a development perspective, to understand this better whilst we're grappling with, just also on the other side, talking about how to provide better care. I'd like to thank you very much for your presentation. I'm sorry, in the interest of time, we're not able to take up all the questions on the chat, but I can see that some of the panelists have been responding to questions in the chat, and I would encourage them to do so. But thank you very much, Dr. Kavita, for your presentation. And I'd like to just hand over to Dr. Sanjay to introduce our next speaker. Thank you very much.
Thank you.
Thank you so much, Jayashree. And our next speaker is Professor Om Prakash. He is a geriatric psychiatrist. He is working at Institute of Human Behavior and Allied Sciences, and previously he was at NIMHANS. And incidentally, these are the two places where I also had my formative training in clinical psychology and neuropsychology. Dr. Om Prakash has been a prolific in publishing many journal articles, around 200 journal articles he has published. He has got several awards, and I'm sure he would be quite pleased for me to share that he got Tilak Venkava Rao Award from Indian Psychiatric Society. And still there are so many awards that he has received. Besides that, he has been on the editorial board of several journals, as well as reviewer for a number of prestigious journals. Following on from Kavita's talk, she discussed more on the neuropsychological needs within the Indian context. But here, Professor Om Prakash, he is going to talk about the mental health need within the Indian context and what the challenges we have. So it's over to you, Professor Om Prakash.
Thank you. Thank you, Jayashree. Thank you, Sarnaka. Thank you, Dr. Sanjay Kumar. I just screen. Good evening, those who are listening me. And I start my slide with this wonderful picture from Karol Bagh. This is in Center Delhi. These ladies, they are participating in one devotional satsang, and they spend their time. The second picture I have, this is something from South India. We can see in the eyes of these this older couple and what they're thinking about. This is another picture from central of Karnataka. There's somewhere you can see that what the state of elderly in India. When I got this topic, I thought there's something what the reality, what the things are there in India, what the challenges, needs, what we have in India. So I remember one song that sung by 50 years back, Beatles. Will you still need me? Will you still feed me when I'm 64? I think that's a very important thing. And because almost in all social media, we talk about some lives matter, other lives matter, but nobody bothers about whether elderly life matters, what are the things we have, what the number we have that we are talking about. See the 3 centuries and the way this graph of elderly, right, from 6.9% in 1900, and by 2000 something 28.1%. And whether we woke up, where we start thinking about this population, like in India, in 1901 we had 12 million elderly persons. 2001 estimated 70 millions, but it's come out 77 million by Indian Census of India, the what data they have. And by 2025, something roughly come 177 million population. With respect to mental morbidity, like host of the problems are there in this population, right? For depression, dementia, psychosis, movement disorder, and a lot of what the medical conditions and drugs, they complicate the whole picture. Like we have patients with psychotic depression, we have schizophrenia depression, we have Parkinson disease, we have NCA, we have all sort of conditions that we're supposed to see in our all outpatient clinics and inpatient settings. So what the problems are there in India, what we are seeing every day? If you go to community studies, right from 70s, they say something up to 350 per 1,000 patients need some help, sort of psychiatric help. The prevalence roughly something 89 to some 300 to 400 prevalence they make out. They make out depression something 50% population, they say there's some depression. Some say dementia something 16%. Something 16, there's something what they make out, and the morbidity what make out from this population, this is roughly very much higher than assumed in our other young population. Come to depression, I think most of the studies from hospital clinics, community, old age homes, they found this big number. Roughly, they in old age homes, there's something find more than 50%. And more important, that most of the patients, if they're visiting the physicians, depression is most often misdiagnosed here. One of the study says, though patients in geriatric clinic, they report they have depression. They report 23% patients say, oh, we have depression. They 18% have depressive disorder, but not a single geriatric physician in that clinic had made diagnosis of depression. And this is very serious. I think something we should talk about that, but because there's something in India, we say that depression is something like defeat of the person. Come to dementia, this is something I think the very silent epidemic in this country. Data varies from state to state. See, the way the lowest data come from somewhat near place from Balagud study from near Delhi, some 0.84. And roughly in Kerala, something 6.7%. So something this prevalence thing and the way people, I think that we discussed about dementia in the previous 2 presentations somewhere. So here India is a big issue, but somehow again this population is neglected. Families are not coming forefront that they're coming to this for the psychiatric or for medical help. The risk factors like diabetes, depression, hyperlipidemia, urban living, lead oxide, these again, most of the researchers, they identify the important risk factors for dementia. I think living in joint families, people say that, okay, we are not become because we are staying in joint families. More increase in take of polyunsaturated fats. They say this is protective factor toward dementia. Regarding anxiety disorders, again, host of populations, I think roughly something 20% up to 30% patients, they reported that they have anxiety disorders. How this big country manage? What things we have, what assets we have, what are the 4 types of resources what I make out. The first set is government psychiatric hospital and nursing home that is state funded. The second set is something private psychiatric hospital nursing homes. Third, NGOs like Samina Care, they are working with geriatric mental health population. Most important, that's very important, that's families. Family is very important asset that this country has. Coming to the first set, that is health professionals. This country have almost 7,000 psychiatrists now, and this roughly getting the whole country of something of 150 crores population. So something this population, I think this is very inadequate with the numbers. What number we have? We have very few Indian hospitals. They have geriatric units. Most of the patients here are treated outpatient setting only. Public sector hospitals, definitely there's problems of inaccessibility, there are problem of inequitable distributions, the lack of staff, this crowding is there, the problem with drugs, the problem with equipments. In the private sector, there are a lot of unregulated, lot of costly affair for families who are looking after the elderly population. Insurance sector. I think that's the, again, very big important one. I would highlight that hardly less than 20% of Indians have some form of health insurance. But this again, the elderly population ignored. What are the other systems we have, right? From there, what are the indigenous system? What Unani, Ayurveda systems are there? They fill this bracket of inadequate health system. What we have, the treatment accessible to this population, they say affordable, but 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 caution is there. Despite this population who are going to these indigenous medical health program systems, they lack specific clinical training with respect to how to check the elderly populations, how to conduct the procedures, and they don't know how to handle primary care emergencies. But large portion of population, they're supposed to visit private institutes, private facilities, and the families they run pay out of pocket. They're supposed to pay money. So this somewhere, what I mentioned, that still this country is moving towards more depending on tertiary care systems, and somewhere primary care and rehabilitation systems still is supposed to strengthen and develop. New initiatives like daycare centers, old age homes, memory clinics, helplines, all other facilities still need to develop, because most of these facilities are from urban cities only. And very important that southern part of India, they have these newer facilities rather than north part of India. NGOs, they're contributing, but still they support to reach the masses, because most of the NGO they're settled in more urban cities, urban areas. Families. I started families as a set for in India at least. And these are families, because the joint system they started, they used to look after. They think that this is our responsibility to look after patients having mental illness. Those elderly we are staying in the family. But again, the era of modernization, globalization, and what are social values what we have, they start this is the breaking of these joint family systems, and now we are moving to a more nuclear system. A lot of things are happening between generations and generations. The traditional sense of duty and obligation of younger generation towards older generation is something erosion is started. And Indian elderly, this generation of elderly, there's something caught between the decline in traditional values and the absence of this social security systems for the health. So this is something the problem. I believe this is a very important problem. Despite we claim that families are important assets, now I think we have to find the other resources. Another problem that is there about very few opportunities for genetic knowledge. These training centers are very few. JT medicine, very few training centers across the country, and regarding JT psychiatry, this neglected branch. Only training special super specialty training happening in Lucknow and Bangalore. Again, big cities. Advocacy research, there are only few organizations they are working for advocacy of this population, right? IGMH, Jet Society of India, Indian Academy of Genetics, and Association of Gerontology. But important is that despite these efforts, this is highly inadequate for this population of elderly. As I mentioned, somewhere, not the facilities, even the utilization facilities were irregular. Because most of the patients approaching the health facilities, there seems to be a higher level educations, those living in urban areas, those who are seeking more treatment for communicable disease, they are approaching these health facilities. Other important issues, non-compliance. They approach the doctor after they fail to visit the doctor. Reason being that they say cost, money. They say that a doctor not providing appropriate instruction. Somewhere they switch the doctor, they switch to other non-conventional treatment. So the important part here, money matters. I think somewhere, because of poverty plays important role the care of this India's aging population. A lot of government policies, but in short, more carrots, less sticks. Article 41 Constitution of India say the state shall, within the limits of economic capacity and development, make effective provision for securing the right to public assistance in cases of old age. This is Article 41 from Constitution of India. But health is not the priority for this government. Not this government, almost for the last 7 decades, not the priority. Roughly 2.5% of GDP is spent on the health, roughly. And if you come to the mental health, then allocation to JT mental health, you can make out that what the amount supposed to be transferred for to JT mental health. There are good policies are there. We are very good in policies. We have national policy for older persons. We have national initiative on care for elderly. We have maintenance and welfare parents and senior citizen acts. But at the end, despite all policies, despite all issues, somewhere there still need funding is a very important part. We have programs starting in 2011, national program for the health for care elderly. Good program. Make out focus of capacity building. We support develop ZT centers or ZT training programs or mass media utilization. But somewhere again, funding is the important issue. Integration from these NGO sector, social sector, health sector, how to amalgamate all these things to provide help this needy population. This again need to be, I think, somewhere we are lacking behind this part. Despite policies, despite all those what big things we claim, the ground reality is that things are not implemented to sense. Most of policies talk about social benefits, but hardly speak about health issues. So what is the way forward? What are we supposed to do to cater this population to at least help this geriatric mental health? Awareness. Somewhere awareness needed. Because I remember when I joined my MD, at that time, some dementia patient comes. So doctor say, there's no treatment for dementia. Just go. Now 2 decades passed. This country advanced a lot, at least providing medications for dementia. Even the cost wise also. Somewhere this message go to the masses that patients having dementia, that this is something, at least we can slow the progress of disease. Somewhere need more awareness. Somewhere these awareness programs, I think something what Savannah Care does and all other NGO doing, media do that. Something is great thing is happening, that we at least we extend this whole exercise of awareness, so that at least we can make engagement between clinicians, researchers, caregivers, and persons who are really suffering mental illness, including dementia. That's again because we need manpower, we need more training programs, we need, so somewhere this need that in the teaching curriculum, somewhere all disciplines has some component of genetic care, right? Physicians, psychiatrists, psychologists, nursing, social work, almost all must have some genetic care component, so at least we can at least enhance this what the motive we have. At least we make out, okay, we're supposed to care about the elderly population. PG sheets programs, they need more funding. We need more funding for genetic care centers of excellence. Somewhere it's more multidisciplinary approach. I think this is very important. Home-based care programs, because I'm associated to ICMRs and a lot of research project I used to see. Somewhere I believe that somewhere this home-based care program actually great asset for this country. So somewhere if groups or research groups come with this training program, at least these programs, which is something this population, these caregivers at least help the person with mental illness. Somewhere those programs are needed, because those programs definitely help to support, educate these families, and this is more, I think, cost effective. Rather, we need say more homes, we need more programs, home-based programs, so that at least in the family they used to perform those and help these our patients and clients. Rehab services again, because we are very good in acute care, that I claim. Somewhere after acute care, what happened to the person? Rehabilitation somewhere we're lacking. We need more strengthening of social sector somewhere, so that at least what the care model we used to claim all the time, somewhere you go for more rehab model, so that at least we can long-term support of the family, long-term support of chronic disease manage, somewhere we to make out and we can say, okay, we have in the, say this district we have daycare center, this pet care facility, we have halfway the old age homes. We need to develop, so at least the care part, we can at least go for the last step, the care, that is rehab. At least we strengthen that part. And the lastly, I think the need for research for models, research for interventions, research for, I think, what we do, what we the social sector, what a lot of things are doing, service sector, what they do, whether we able to generate the research data for that, and at least we can help, we can shape this data, at least we can shape this policy, then we can help the government for making better services for these populations, at least for the carers. To conclude, in this country, definitely executive mental health is a neglected issue among patients, caregivers, policymakers. A lot of efforts need to be done to make treatment or services to accessible to everyone, affordable to the community. Definitely the need for awareness. That's more, I say all the say, we need ABC of at least GT psychiatric disorders, at least for dementia, at least for depression. This more strengthening of intersectoral collaborations. Definitely they need to implement what we have, great policies, national policies, programs, or what are the acts we have. Because these acts and policy, they're meant for this population, but somewhere support groups are lacking, somewhere we need empowered, at least we help them, at least the support group, generate support group. We need carer groups to add for these advocacy programs at least. I think we can do more. We can do more for this. Thank you. Thank you. Over to Dr. Sanjay.
Thank you. That's a very passionate presentation, and I'm sure everyone would agree that you have very succinctly outlined the needs and challenges that Indian community is facing in a caring elderly population. There are a few questions, although some of the questions have been answered in the chat forum, but I will take your ideas on the questions as well. Questions are, it's more about the regional variation and the prevalence of dementia. Do you see any such pattern? In India, different states might have different prevalence rate. And particularly the question is related to Kerala, if Kerala has got higher dementia rate, and if it has any particular reason why they should have.
Okay, I think there's a lot of studies coming when this is something National Mental Health Survey data come, and it states that somewhere prevalence is something very not uniform across the country. Like Bihar, there's something I'm talking about dementia. Something, the Bihar is the highest. There's something they say they claim the Kerala is the highest, but some states like Bihar, Odisha, they are coming up with dementia. They're coming more with psychiatric problems. There's something very interesting data is coming, and reason being that somewhere people are now getting aware about the problem somewhere, because awareness is again the big issue. People, the problem with the elderly this mental health services is that elderly people, persons, community says, oh, aging, this is not illness, more about dementia basically. They think this is something getting old and supposed to go to die, and why bother about the dementia thing? So they're not aware about quote unquote term. The person you compare from Bihar to Kerala, literacy, there are a lot vast difference. Awareness is again vast difference, but that's not the actual scenario. People, Kerala, some other region, definitely their literacy, their awareness more. There are other factor the issues because we have studies what are coming from Kerala. They are more sort of the coconut diet, coconut oil they used to use that way. There are social factors are there. Alcohol is one important factor they make out. As compared to prevalence of alcohol, Kerala comes highest among the all states of India. So a lot of host of factors because dementia is again multifactorial. Not only one factor we can pick up and they make out that Kerala has highest prevalence. But studies say in this way that Kerala is highest where as compared to northern India, they have lower prevalence of dementia.
Right. Oh, yeah, that's quite interesting. Second part of that question, although that has been answered, but I would like to have your opinion on that. So Kerala has got highest literacy rate in India, but it still shows those typical kind of higher dementia prevalence. How does you see the role of cognitive reserve playing a part in dementia?
So the last line, counter research.
No, the role of cognitive reserve, the capacity.
Yeah, I think that this is very, I love this concept counter reserve because somewhere I believe that because they high literacy rate, the chances of that using the brain, this population of Kerala high literacy, they are using reading more things, reading newspaper, doing all activities of more of higher cognitive skills. Somewhere I think this counter reserve is high as compared to rest part of India. Literacy has issues. Literacy that directly proportional to the counter reserve. So high literacy means high counter reserve. So undoubtedly, the elderly population which are say less literate, less engaged in activities, less remain lethargy, definitely they have less counter reserve. So that's the reason that Kerala is high count. Possibly, I don't think any studies there, but possibly they may high counter reserve.
Yeah, right. And would that act as a protective factor against dementia?
Counter reserve.
Yeah.
Yeah, definitely. I believe that there are a series of papers from appears in Lancet and JAMA. They something say the counter reserve is very important asset for protecting dementia. But the way around, this is again multifactorial. Counter reserve is one issue, but other issues like alcohol, like coconut oil, like the dietary factors, like what they eat. People say the omega fatty acid they eat more or fish they eat more. A lot of things are there. So only depending counter reserve is not the final answer. So the other host factors that implicate somewhere because Kerala again, because I remember in Nimans we had a lot of discussion about Kerala and what the prevalence or why they think it was this something. So no definite answer of this that if county high reserve is there, the why they have more dementia. No definite answers.
Yeah. 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 Probably that was the question that someone was trying to ask from the pen. Okay. Although this has been answered previously, but this is a kind of recurring theme in the questions. Role of the social isolations and dementia and problem with elderly population. So what your thoughts are on, particularly within the Indian context?
I think what loneliness syndrome, the new syndrome come up in genetics, something called loneliness syndrome. Somebody more lonely, more depression. This something a chain cascade chain is there. So depression, patients are more depression, they have more chances of dementia. They are more, so they have maybe a count changes, but not amounting to dementia. That's not the conclusion of this whole because loneliness is the one risk factor is there, but not leading to dementia. May have some county changes, may have more chance of depression, but not per se dementia.
Yeah, no, thank you. And I don't see any other questions. And thank you for your wonderful and passionate presentation. That's
Thank you.
Really interesting. And now I will hand it over to Jayashree if there are any business to the house, please.
Thank you, Sanjay, and thank you once again to Dr. Om Prakash. I think we've had a really interesting discussion. I can see that there are a lot of questions that were being discussed also in the chat. So I think this has been really very insightful, all the presentations. And on behalf of PSG Institute of Medical Sciences and Research, the Department of Psychiatry, as well as Samvedna Senior Care, I'd really like to thank all the speakers for taking out their valuable time during, the very busy online lives. I mean, the presentations have really gone across highlighting various very important aspects, right from the dementia tsunami to the impact that this has on caregivers, the challenges that are faced by care partners, right up to the fact that we really there is greater need for more research in these areas, not only when it comes to early screening, diagnosis, the kind of tests that we need to use to identify these conditions, but also about the basic lack of services to support individuals facing these kind of challenges, and therefore a greater need for more advocacy in these areas. So it's been an absolutely fantastic discussion, and I really want to thank all our panelists for their time and their wonderful talks. I'd also like to thank all the participants who've joined in today. And we really look forward to seeing you again for the fourth and the final symposia in this international symposia series. We have a wonderful panel of presenters who'll be talking about a very interesting area, the self in cognitive neuroscience. And I really think that this would be an area that's not only going to be very relevant for all mental health professionals, students, but researchers as well as academicians. So I really would encourage you to spread the word about this symposia, and look forward to seeing you all again for that. So thank you once again to all our panelists, and thank you once again to all our participants, and look forward to seeing you again on 26th of February at 6 p.m. IST. Thank you.